Hi, my name is Annie Coates, and I'm a pediatric pulmonologist at Barbara Bush Children's Hospital and Maine Medical Partners.
And I'm Genevieve Whiting, and I'm a pediatrician at Maine Medical Partners in Westbrook.
Genevieve and I are here to review our referral guidelines for patients with chronic cough. These guidelines are two of over 30 guidelines that pediatric specialists at Barbara Bush Children's Hospital have compiled to assist primary care providers with decisions about when referral to one of our specialists is needed and when there are opportunities for co-management and treatment in the primary care physician's office and would be most appropriate for the patient. These guidelines were compiled in collaboration with many of your colleagues in primary care.
This presentation is meant to be a brief and informal discussion of the chronic cough guideline. The goal is for primary care providers to receive a concise update on current standard of care for a topic they may be addressing every day.
Great, Genevieve. Thank you. So let's get started with the chronic cough guideline. Among the guidelines we've worked on, this is one of the most straightforward. This is a very common, if not the most common, chief complaint for primary care physicians who care for children.
I couldn't agree more. Cough often impacts the quality of life of both children and their parents, and the exploration of parental expectations and fears is often valuable in the management of cough in children.
So cough can be defined in many ways, but based on the time frame, such as duration of the cough, the quality, is it dry or wet, brassy or staccato, or suggested etiology, which may be specific or nonspecific. Chronic cough in children is defined as a cough of greater than 4 weeks duration. This is because most acute respiratory infections in children resolve within this interval. Other schemes define chronic cough as one that lasts more than 8 weeks, but also recognizes that a relentlessly progressive cough often warrants evaluation prior to 8 weeks. So in general, how we guide families is to prepare them for a cough to last at least 2 to 3 weeks per respiratory illness. And in the wintertime, living here in Maine, it's not unusual to have at least 6 different respiratory illnesses per winter. And so it's not unusual to have several weeks of the winter be affected by cough per illness with children. But as long as the cough is otherwise getting better and there are no other concerning findings on exam, we really just reinforce that guidance and reassurance for families. So Genevieve, having said that, let's say you have an 18-month-old female in your office for an initial visit for cough that's lasted 1 month. It's February. What would be your approach?
So my evaluation of an 18-month-old child with chronic cough would include a detailed history, physical examination, if indicated, possible chest imaging, and spirometry if the child is able.
Yeah.
If the initial evaluation provides clues suggesting a specific cause of the cough, further evaluation is focused on that diagnostic possibility.
So based on your evaluation and reviewing our low-risk green recommendation, you decide to initiate treatment for asthma.
Yes, I would initiate a low-dose inhaled corticosteroid to be used twice a day, such as Flovent, 44 micrograms per puff, 2 puffs twice a day, in addition to as-needed bronchodilatory, such as albuterol.
That's perfect. It's important to reinforce that the inhaled corticosteroid works best if used consistently twice a day. It is not effective as either a once-daily therapy or when used as needed during acute illnesses. In addition, the use of an aerochamber, which may or may not be with a mask, is important to improve medication delivery. Without it, the majority of the medication is deposited in the posterior oropharynx. The equivalent dose of 1 albuterol nebulized treatment to albuterol MDI, or meter dose inhaler, is about 4 puffs. So proper dosing of these therapies and device technique is crucial. Your patient's cough has improved on these therapies mentioned above. So now let's say it's May, and this toddler redevelops an intermittent nighttime cough as well as chronic rhinoconjunctivitis. That brings us to our yellow moderate risk guideline. Approximately 1/3 of individuals with asthma have environmental allergies. Collectively, we need to do a better job at treating underlying rhinoconjunctivitis, both by providing education on allergen avoidance as well as prescribing and teaching appropriate use of therapy. We have the ability to perform allergy testing in our office, But to clarify, that's to airborne allergens, not to food allergens. So based on the guideline, what would be your next step in evaluation and/or treatment?
So based on this new history and examination, I would perform allergy testing, perhaps in conjunction with your office, pulmonary, and treat any evidence of environmental allergies. Would you recommend anything different if I found nasal polyps on my examination?
It's a great point, Genevieve. Nasal polyps can be found in the setting of allergic rhinitis as well as in cystic fibrosis. So although all infants born in Maine who consent to newborn screening are screened for cystic fibrosis, if there's a clinical suspicion for the diagnosis, I have a low threshold to evaluate for it, which includes obtaining a sweat chloride analysis.
So that brings us to the high-risk situations. If there are other findings such as clubbing, evidence of malabsorption, decrease in weight trajectory, it would be reasonable to consider these other diagnostic possibilities such as cystic fibrosis.
There are over 2,000 mutations known to cause cystic fibrosis, many of which we are just starting to learn the phenotypic-genotypic relationship.
So that summarizes our chronic cough referral guideline. The take-home points include, in the setting of chronic cough with complex medical issues, for example, trisomy 21, consider a referral. A normal chest x-ray does not rule out foreign body aspiration, as most foreign bodies are not radio-opaque. If clinical symptoms or findings suggest cystic fibrosis, sweat testing should be done even with a history of a normal cystic fibrosis newborn screen. Cough suppressants and other over-the-counter cough medications should not be used in infants or children. Repetitive, dry, honking cough that is absent during sleep is suggestive of a habit or psychogenic cough. Consider vocal cord dysfunction in adolescents with a history of throat tightness, respiratory distress, or noisy breathing on inspiration with or without anxiety in the absence of infection and/or chronic cough. Protracted bacterial bronchitis is defined as a wet cough, positive bronchoalveolar lavage, and resolution with prolonged antibiotic therapy. Annie, I know your division wanted to emphasize that we can reach out to you with any questions.
Absolutely, yes. We have a wonderful group. When you need to refer, please send the patients and families our way. If you're not sure, we would be happy to talk it over and give general advice to help with your decision making. The contact information will be with each of the guidelines.
Great. Well, thanks so much for doing this, Annie, and engaging primary care providers in this process. I know they were involved in critiquing the guidelines. And thank you to everyone watching. We hope you use these guidelines and encourage you to take a look at some of the other videos online.
Thank you, Genevieve, and everyone.